I really want us to move in the direction of categorizing and classifying central lines so that we can stop talking about brand names. Many of the brand names we actually use no longer exist. I always say there's not a single bullet to prevent CLABSIs, and a lot of institutions throw a lot of tricks and gadgets at CLABSI prevention. In my organization, we've really tried to focus on the basics of catheter care. It's not always one size fits all. Risks and benefits have to be thought of before you decide just to put a central line in everyone.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS, and today we are joined by ONS member MiKaela Olsen, Clinical Program Director for Oncology at the Johns Hopkins Hospital and Johns Hopkins Health System in Baltimore, Maryland, and member of the Greater Baltimore and Mid-Chesapeake Bay ONS chapters, to discuss preventing central line associated bloodstream infections and other best practices for central lines. Thanks for joining me today, MiKaela.
Thank you for having me.
So to start us off, what types of central lines do oncology nurses use in their patients?
This is a great topic, and I always like to teach nurses in oncology to really know their line types. It really helps us with management and to minimize complications. The most common central lines that we use in oncology include two main types that I refer to and we see in the literature: non-tunneled and tunneled central lines. Non-tunneled central lines include short-term subclavian and jugular lines that we mostly use in acute care settings. The non-tunneled means that the line goes directly from the insertion site where the provider is making that first incision into the vein, and then the tip is threaded from that vein directly into a central location. Non-tunneled line types include large bore catheters used for dialysis and pheresis, as well as the smaller types of catheters. And patients don't typically get discharged with a non-tunneled central line unless they're going to a facility that knows how to manage them and there's a good handoff process to that facility, such as a rehab facility or another hospital. And non-tunneled lines can be placed at the bedside by trained staff. The tunneled central lines are defined as such because the initial point of insertion during surgery differs from the catheter exit site, and the catheter is tunneled between the skin and the muscle. It usually exits lower in the chest area. So it's important to know, if you're an oncology nurse, am I dealing with a tunneled line or a non-tunneled line? Often tunneled catheters have a cuff that sits in that tunnel, and that's really important because the cuff in a tunneled catheter has two purposes. It can and is often coated with an antibiotic, and for a short period of time after that tunneled line is placed, that cuff gives off that antibiotic and helps prevent tunnel infections. But another really important reason for that cuff is that fibrin starts to form around that cuff right after that catheter is inserted into the body in that tunnel. And that helps secure that tunnel and that catheter into the tunnel. And ultimately that helps prevent dislodgement. So tunneled lines are considered our longer term lines. Patients can go home with them. There's less risk of them dislodging in the home setting. They have lower rates of infection over a non-tunneled line because they have that point of entry and tunnel going up before it hits the bloodstream that can help minimize the risk of infection. They are at risk for an insertion or tunneled infection, of course, just like any catheter would be. So that's kind of in a nutshell, the difference between tunneled and non-tunneled catheters. Tunneled lines also are used for large bore lines like dialysis and pheresis catheters. So patients that require these treatments long-term and are going to be discharged need to have a tunneled dialysis or pheresis line. we don't typically send people home with non-tunneled large bore lines because of the risk of dislodgement and bleeding risk. Tunneled lines are typically placed in an interventional radiology department with the use of fluoroscopy. And in addition, after you figure out if you have a tunneled line or a non-tunneled line, the two main types of central lines that we use in oncology are implanted ports and peripherally inserted central line catheters. So these are two additional types of lines. The implanted ports are used mostly in patients who are going to need access for 6 months or more. And ports are often placed in interventional radiology. And the insertion is similar to what I described with the tunneled lines. So just to give you a form of reference, non-tunneled short-term lines are usually those that we place in acute care settings for patients that need immediate central line access, and we don't necessarily need to put a long-term line in them yet. We just want to get them through a period of time with a non-tunneled acute care catheter. And then often if the patient needs continued access, they will be sent to get a more permanent catheter, such as a tunneled catheter. That can include any kind of a tunneled central line catheter. And there's a lot of brand names out there for these kinds of catheters. You may still say those names in your organization. And I've been trying to get people to not talk about a brand and instead classify the central line in terms of its functionality and how it's placed and maintained. So starting with that tunneled and non-tunneled distinction is really important. And then large bore and regular or small bore is another distinction. And implanted ports fall into that tunneled categorization, with the exception of the fact that there's nothing external when they're not accessed, like there would be with lumens of a tunneled catheter. The peripherally inserted central line is considered in most of the literature to be a non-tunneled line. It just gets placed in either the brachial, cephalic, or basilic vein, and it is placed immediately into the vein and threaded into the central access area, into a central vein. So we'll talk a little bit more about PICCs later, but ports are often put in patients who, as I said, are going to need access for 6 months or more. It is a procedure done under anesthesia, so people will go to interventional radiology most of the time to get their ports placed. Some people do this at the bedside with local anesthesia, but in my institution, we send them to interventional radiology. They return from the insertion with an incision near their neck at the jugular vein, and the port is placed in that tunnel in a pocket between the skin and the muscle in the lower chest. And the port will have an incision over the upper outer area of the port when they come back from that port placement, and we have to monitor that until it's healed. Implanted ports, interestingly, can also be placed in a basilic or brachial vein in the upper arm, and that's very similar to a peripherally inserted central line that we normally call a PICC line. So it's essentially a PICC line, but it's really put in the same location, but it's an implanted port. And those can be really useful. I often recommend those for my patients who just don't want to have any scarring on their chest area and really don't want that to show. And having it in the inner arm area like a PICC line can be really appealing for some patients. And then the last thing I wanted to just sort of review again are the PICC lines. They're probably one of the most common types of central lines that we use in our patients. They are often placed by nursing teams. And I know in my organization, I am the PICC team manager for oncology, and I have 10 oncology nurses who, of course, work on different units taking care of cancer patients in the inpatient or ambulatory setting, but they are competent and trained in the insertion of PICC lines and are also some of our vascular access expert committee members. And they really provide a wonderful service of placing PICC lines in our cancer patients. These lines are much less expensive. It's cheaper to buy the kits and place the lines, and they can be done at the bedside using maximum sterile barrier technique. And PICCs can be left in for long periods of time. People sometimes think that PICCs are temporary catheters. They can be, but they can also serve our patients for long periods of time. And I've had patients that have had them in for up to 1 to 2 years. PICC lines do require care and maintenance, and due to their location, the patient does need a caregiver or help from the organization in an ambulatory clinic or home care environment to be able to get those dressings changed and to do the flushing. Other non-central commonly used lines in oncology are peripheral IVs. And remember that peripheral IVs are never central. They're classified as short or longer types of peripheral IVs, which we refer to as midlines. And so that's just, I know that's a little bit extensive, but I really want us to move in the direction of categorizing and classifying central lines so that we can stop talking about brand names. Many of the brand names we actually use no longer exist now that we have better catheter material and catheter technology. So it's important to start using these new ways of describing our central lines. So I hope that helps.
Thanks so much. That was a great overview of what those central lines are. And I agree with you. I like, what you were saying about really understanding the type of lines that they have rather than going by a brand name, because it's more about understanding the type that's in there and what you do with that, all of the things that go with the type of line.
Right. Exactly.
So MiKaela, you talked a little bit as you were going through that, some of the indications for central lines in our patients with cancer, but can you maybe give us a little bit more information just about why a patient would definitely need to have a central line placed?
There's really been a strong movement to avoid central lines due to the morbidity, mortality that's been associated with central line infections and other complications. However, all oncology patients really deserve a thorough assessment of their veins at the time of diagnosis and with each visit. And we really have to consider upfront. I always say, let's try to get the right line in the right patient at the right time. We really have to consider a lot of things, including the patient's preferences, before we place central lines in our patients. If they're getting continuous vesicant therapy, we know that that is a requirement for a central line. If they're getting regimens that contain a lot of irritating drugs and drugs with vesicant-like properties, and we already see that this patient has vein health issues, that would be a patient that we might consider that the risks and benefits after they have been considered, that we are going to be placing a central line on that patient up front. There are patients with severe needle phobias that may not be able to tolerate getting a peripheral IV and a blood draw for their chemotherapy or immunotherapy every cycle. There are patients that have cancer that end up having critical care needs, and while in an acute care environment, will need to get a central line oftentimes if they have a need for vasopressors or other therapies that require that or frequent access. Poor vein health I mentioned, and then of course our patients who are undergoing treatment for acute leukemia induction, hematopoietic stem cell transplant, or other cell therapy programs. Those patients often require a central line because without that central line, they would require just so many sticks for their blood draws and all of their supportive care and treatment therapy. And sometimes in patients with end of life who require pain management or other therapies, a central line can be a good option. But there are other options available for those patients. And oftentimes our PIC team will get called to put a PIC in someone that's going to hospice for their PCA pump. And I try to remind people we do have the ability to give hydration and pain management through subcutaneous PCA pumps and other types of infusion pumps. And we can also do high concentration oral therapies in these patients if possible. So even a consult like that for our team at the end of life would require that we really think about the situation. And again, we really do avoid putting it in if it's not necessary, but there are plenty of reasons why central lines are indicated in our patients.
Thank you. I have to tell you, even as a nurse and, working with the patients that I have over the years, I personally have that needle phobia. So we are our worst patients sometimes. And
Right.
I always said that, if I ever needed, I would prefer to just please ask them to put a port in because I know how I would feel about all of that. And it's really important to take into consideration, those things like you were mentioning with our patients and really helping to determine what is going to be the best option for them.
Right. You bring up a really good point. And I've had the opposite happen where I've had patients that said, absolutely not. I want to use my veins. I don't want anything put into me. I don't want to have a central line. I don't want to have to care for it. And so it is so important to include the patient in the decision making and really let them understand all the risks and benefits and all of their options. So great point.
So in speaking of that, when a nurse is working with a patient and, it doesn't have to be a new patient. It can be someone that has been on therapy for a while, or like you were mentioning, end of life and things like that. What are some considerations that nurses should keep in mind to guide that catheter selection? I know we've talked about it a little bit, but, there are some other things that they might need to know in helping that decision making.
Yeah, well, just to expand a little bit more on the patient preferences, you kind of have to do a little bit of a deep dig because patients may not always let you know things that might be really important. For instance, I've had a patient who forgot to let us know that his most favorite thing to do when he was well enough to do it and on his days off was to play golf. And the docs ordered a PICC line. It was the appropriate line for that patient at the time. And then all of a sudden, a week into his PICC line placement, he calls our triage line and asks if he can go golfing. And, we try to avoid repetitive movements in the arm where the PICC is, especially something like a golfing with that arm, just because we can cause pistoning of that catheter and that can cause infection. It can cause catheter tip location malposition and pain and other problems. And so those are the things that we need to talk about with our patient. What are their hobbies? What is their lifestyle? What is their ability to care for their catheter? I've had patients get lines and no one talked to social work. No one talked to the patient about their ability to pay for the supplies, which, by the way, are not cheap. And it's important that we consider all of that up front. Do they have a caregiver? If you put a PICC line in and they can't change their own dressing with one hand, do they have somebody that can be taught how to help with the dressing changes? Can they come back to the cancer center every 7 or the infusion clinic every 7 days to get that dressing changed? And who's going to help them flush that catheter? So lots of things have to be considered up front. How long is the access needed is a very important question. What types of therapies are going to be given through this catheter? What is their long-term plan? If they're going to be sort of getting some initial therapy and then considered for CAR T-cell immediately, then maybe we should put the tunneled long-term catheter in early on so that we don't have to take out a catheter and put in a new one for that patient. What are their individual patient risk factors? I think that's very, very important to consider. Have they already had a PICC on one of their arms and developed an occlusive thrombus? That might change our thinking about putting in another PICC on the other arm. Do they have high risks for infection and other problems, such as maybe they have a trach or a stoma and they have a lot of secretions? Well, maybe we shouldn't put a chest central line in that patient. We should consider a PICC line so it's away from that area where a lot of the bacteria is. So lots of individual patient risk factors that need to be considered. Do they have a fistula in one of their arms? And we would want to stay away from that. Do they have kidney disease? So we have checklists for those of us that place these lines, but oncology nurses that are helping in this decision-making or teaching the patient can also consider these things. And then, can a patient be supported with peripheral access? We have a lot of patients that we have gotten through ABVD, for instance, for Hodgkin's disease. It's a limited number of cycles. And if you've got a young patient with pretty robust veins, it's sometimes much less traumatic for that patient to go through those cycles peripherally than to get a central line that they then have to care for and that we know is associated with complications. So again, it's a patient preference. It's a assessment that's needed, and we have to think about risks and benefits. And then many of us are expanding our use of ultrasound guidance for the insertion of peripheral IVs and midlines. And I know personally from teaching this for many years now and providing this option for patients that it's really expanded our knowledge of people's vein health. You can really see a lot with an ultrasound. And if you're an expert in ultrasound guided access like I am, you can really make good decisions about vein health and whether or not we should even be using patients' veins for these kinds of situations, like chemotherapy and immunotherapy administration, because our ultimate goal is to do it safely, not cause long-term thrombophlebitis, and also to not cause extravasation or infiltration. And by using ultrasound, you can seed those peripheral IVs deeply into veins to prevent extravasation, and you can ensure that you have a healthy vein for your access, thereby eventually, hopefully, eliminating the need for central lines in some patients that are eligible for that.
Thank you. Again, so much information that needs to be considered with our patients in these lines. So as you know, ONS has communities where members can post questions that they have, and then other members can respond. And so we have some questions that we found on the ONS communities discussions about central lines. And I just wanted to ask you a couple of these questions. So one of them was discussing maintaining proper catheter tip placement throughout treatment. So how does placement differ depending on the type of catheter, and why is it important to check the tip placement? Because we want to make sure that nurses are ensuring safety, prior to, during, and after treatment. So what does that look like?
This is a great question and something that I'm really passionate about. Central lines should all be placed with the tip of the catheter somewhere in the superior vena cava. But even more specifically, the ideal location for a central line tip is really in the superior vena cava right atrial juncture. We nickname that the sweet spot. We nickname that the bullseye, an area where we have very good flow of blood. I've read that is upwards of 2 liters per minute is the flow of blood in that area. And that's really the ideal location, according to most of the literature that I've read and the guidelines that are out there, to help minimize complications and to ensure that we have catheter longevity. The flow of blood in this location helps assist with the prevention of malposition, thrombus, and some have said potentially infection, because again, anytime you have thrombus or occlusions in catheters, that's associated with infection. We know that dialysis catheters are a little bit different than the rest of our central line catheters. They usually terminate in the right atria, so just a little bit deeper, but most central lines, we want them at that juncture. And it's cool because as a PIC nurse, and this is something I presented at ONS years ago, we were able to move forward with a new technology using ECG. So we put leads on the patient during the insertion of the catheter, and we're able to see the patient's P wave on their EKG, and we can see the catheter P wave, and we can tell when we're going down into the SVC, and they even color code the rhythm so that it's yellow as you're going down, and it turns green when you hit that SVC right atrial juncture, and telling you that you're at the right location, and then it'll turn red if you go too far into the atrium. And we don't want a catheter too far into the atrium because it could cause arrhythmias. So we've got wonderful tip location technology now outside of interventional radiology, where they use fluoroscopy to help us at the bedside so that we can get our catheters in the right location. I know a lot of you have probably experienced a situation where you were taking care of a patient and they complained of a whooshing water noise in their ear. And that's because the catheter tip had flipped up into the jugular vein, and now they were sensing that in their ear when you flushed it. That's a really good indication that it's malpositioned. And we've seen all kinds of malpositioned catheters where the tip started out somewhere in the superior vena cava, but now has flipped up. And that, remember, we have power injectable catheters now. We're sending them to CAT scan, and we're giving CT dye at very, very fast infusion rates, up to 10 cc's per second. And if your catheter isn't placed with that tip down deep in the superior vena cava, the patient's more at risk for that catheter tip flipping up. We know that other things like intrathoracic pressure changes coughing and suctioning and other things can not only cause catheter occlusion, but they can cause the catheter tip to be malpositioned. So the tip location is really, really important. And there was a study that I like to refer to. It's a little older now, but it's a really good study done by Bass and colleagues in 2011 that helps demonstrate the importance of tip location. They looked at over 1,000 central lines that were placed in 858 patients. And they found that the single most important factor in central line catheter longevity that was influenced by the surgeon's placement was the tip location being in this SVC right atrial junction. Those catheters that were placed properly lasted longer and had less complications. And there are other studies that have shown the same thing. So long-winded answer for what should be a pretty simple explanation, but catheter tip location is one of the most critical parts of placing these lines. And so technology really does help. So fluoroscopy in interventional radiology and for PICC lines or ECG technology, these have been really, really very instrumental in helping us get these catheters in the right location. But this is a bit of a battle. I just had one of my treatment area nurses call me the other day saying the catheter's no longer in the superior vena cava. The doctor says it's in the brachiocephalic, and the doctor says we can still use it as a central line, and the patient was getting vesicants. So the more we as nurses can be knowledgeable about our tip locations, really understanding and knowing where that tip is located and making sure that we do in fact have a central line, because lines that are not somewhere in the SVC and ideally in that juncture, as I described, are not classified as central lines in most people's minds. And I know that in pediatrics, they do use alternate sites because of a lot of restrictions with pediatric patients. But in the adult side, we really, really consider central lines to be somewhere in the superior vena cava. And as I said, that will bring us to better catheter longevity and less patient complications.
Thank you for that. So we have another discussion thread that we found on the communities, and this one was about implanted port maintenance. What is the standard practice for accessing and flushing implanted ports, and what patient education points should nurses emphasize to help ensure the port remains functional?
Okay, that's another great question. So when accessing an implanted port, it's important that we use aseptic and a no-touch technique over the area where we're accessing. The entire area over the port, and I tell nurses, you're going to put a dressing over that port. So you need to include the entire area over the port and the width of the dressing in when you do your scrubbing. And probably before anything is considered, we have to think about the technique around how we're scrubbing before we insert that needle. And I often see people kind of go for like 2 seconds over the port or quickly go around in a circle over the port, then not even let it dry and stick the needle in. So I'm going to describe to you the proper way that we should be skin prepping our ports before we access the needle. We really need to use a chlorhexidine scrub for 30 seconds using a back and forth motion similar to what we would do for a surgical scrub, and use friction. It's really important. And 30 seconds is a long time. So you really need to use a timer or a clock or something so that you can watch how long you're scrubbing for, and just talk to your patient and continue to scrub. And if the patient's complaining that it hurts because the port was inserted recently, you can use a little bit lighter technique, but you really need to do a good scrub back and forth with friction. And then the other most important point is the chlorhexidine works best when it is allowed to dry. It only takes between 30 and 60 seconds to dry, but allow that to dry completely before you access the port with your needle. And then, of course, you're going to use your hands to stabilize the outside of the port before you put the needle in, but you're not going to touch that area over the port where you access it. In my organization, we have found that using a port access kit has really helped standardize the procedure. It makes it more redundant. It makes it easier for staff to follow our competency and our procedure because they have everything they need in the kit. It also includes some pretty cheap little sterile drapes that can be placed over the patient to allow for some privacy and allow for you to be careful about not touching their clothes or their skin and other things. So we found it useful to use a port access kit that we were able to negotiate for our patients. But if you gather all the supplies, that's okay too. Just make sure you're using an aseptic technique and cleaning the area under like the table before you set up your access area. So those are the most important things when accessing a port. If the patient comes back from surgery and they have that glue over the exit site right near the port, you can still scrub that area lightly with chlorhexidine. Chlorhexidine is compatible with the glue, but it's important that you allow the glue not to be scrubbed off because that's going to help. It's obviously keeping that wound closed and helping it heal, but it is important that we clean over the glue. So you're going to lightly clean with your chlorhexidine over the glued incision area, and then you're going to use more friction and scrubbing over the actual port area before you access. That glue will generally fall off similar to steri strips in about 10 days or so, and you want to just let it fall off naturally so that incision can heal very good. If you leave the needle in a port, then the needle and the dressing should be changed together every 7 days. And there is an exception to that. If the dressing becomes compromised, is no longer intact, if the site has any blood or drainage around that needle, then that dressing needs to be changed immediately and care needs to be taken so that you don't dislodge the needle during the dressing change. And for flushing an implanted port or any other central line, the most important thing really is that we have to remember that the flushing is helping us maintain catheter patency. And I always say there are 5 opportunities for flushing: after every blood draw, after every med administration, after we give blood products, and if we notice any blood or debris in the lumen, and on a routine basis per your institutional policy. And when we flush, the flush has to be a pulsatile flush. You want to use a push and stop method, and you want to do that every 1 cc. This pulsation or turbulence is really, really important. This is the most important factor in the prevention of occlusion, and we know that occlusions can cause infection. So we need to flush frequently. We need to flush with pulsation, and this will help us maintain patency and reduce complications. And for patients, I would say just encourage them to, if they have central lines, in addition to implanted ports, to always encourage them to have good hygiene, and for implanted ports specifically, to make sure that they keep their appointments for their flushes. And I know this was really challenging for us during the pandemic. We had so many people calling in that needed a central line or an implanted port flush, and they didn't want to come into our institutions. And we had some people that didn't show up for their port flushes or their central line flushes. So we stood up a curbside clinic in both of our oncology clinics. Right on the curb, we had a nurse and a nursing technician and all of our equipment and supplies. And to this day, we've cared for about 5,000 or more patients since the pandemic started in our curbside clinics. And catheter maintenance, flushing, dressing changes, all that's been done in our curbside clinics, so the patient doesn't even have to leave their car. And we've had amazing success with that. And during that time, we did actually extend our flushes out a little bit, which I think we'll talk about in a few minutes.
Thank you. Those are really good points that we need to remember during caring for ports. So you did mention a little bit about flushing. And that was another discussion thread on the communities that came up. And it is talking about flushing with heparin and how there are institutions that are no longer flushing with heparin, and just there's so many questions around flushing ports and what is the effectiveness? Should we be using heparin, or are we just using normal saline or alteplase? So can you just talk to us, about those questions that some members had, about just the whole practice with flushing ports and what to use?
Sure. Well, currently there isn't a consensus about the optimal flush interval for implanted ports. Historically, this has been done monthly for most patients when not accessed. However, there are recent studies suggesting that prolonging the flush interval is effective. And we actually did that during the pandemic and had great success. The studies that I've read, some have looked at an 8-week flush interval, and I've seen up to 90 days. And so I know there was a recent article that was published in CJON by Donna Ignatios and Crystal Gloria that looked also at saline versus heparin in flushing ports. But most people know I have a lot to say about this because I did my DNP on this topic, and I actually looked at the elimination of heparin in our oncology patients here in my organization. We know that heparin is associated with lots of complications, such as heparin-induced thrombocytopenia and bleeding. We know that heparin increases the formation of biofilm, which is that sticky matrix substance that's inside and outside the catheter. And heparin can increase the formation of that. And that biofilm often harbors bacteria and can increase catheter-related infections. And we also know that heparin is a porcine product, and we don't really inform our patients that this product is made from pork. And some patients may not really appreciate the fact that they're receiving a medication that is made in that manner. And so for the other one that I didn't mention is anaphylaxis. And in my organization, we've had in the last couple of years, a couple patients have severe anaphylaxis after a port flush with heparin. And so we want to make sure that we are using the safest thing. I know many of you remember in the 90s, we got rid of heparin in our peripheral IVs, and now we call those saline locks. We got rid of heparin in our arterial line setups in the early 2000s. And now there's a lot of literature, a lot of movement toward saline in our central line catheters. I always say my biggest word of caution is that although there are studies showing that saline works as well as heparin and with reduced harm and cost, I believe that the most important thing is in the hands of the oncology nurses and patients, and that is the way we flush and the frequency of flush. Because even in my work, I noticed that if the catheters are not flushed frequently and the pulsation is not used, there is higher rates of occlusion. And so even in our heparin groups, we use a lot of alteplase. We can reduce alteplase no matter what we flush with if we properly flush the way I described. And what I found in my work and others have published is that when you properly flush with the right frequency and with pulsation, saline can be as effective as heparin, and you can eliminate that cost and harm to the patient. So I am really excited to say in my organization that we have been live since January of 2020 with saline only in the entire cancer center for all central lines, including our large bore lines. And that means so much to me because when I analyzed the amount of heparin we were giving and the cost and the amount of alteplase that we were giving, it just was amazing. And it's so much easier for the nurses and patients to use saline, and it has really benefited us. But it will not work if there's not a really, really good flush program teaching for the patients and the nurses. So that's, in a nutshell, a little bit of a discussion about heparin versus saline. And I kind of expanded it to all central lines because it's really not unique to our ports. But there's some good evidence with ports that everybody should look at in terms of the interval and the saline.
Thank you. So another area we really haven't talked too much on would be CLABSIs. So why should oncology nurses be aware of these central line associated bloodstream infections, and what daily care considerations can help them prevent this adverse event?
So the prevention of CLABSIs is just such a huge topic. And we actually do like an 8-hour skills day workshop and CLABSI fair in our organization to teach this, because the prevention of CLABSIs is not a single intervention. Prevention of CLABSIs is a whole host of bundled activities during insertion and maintenance that help us prevent infections. And it includes the person inserting it, the people maintaining it, and the patient and their caregiver, of course. And it's so multifaceted that we have in my organization a CLABSI committee, and we have a CLABSI champion meeting. We have one champion from every unit in the hospital that leads this effort in their individual units. And we have topics that last for an hour each month that focus on one aspect of CLABSI prevention. So as you all know, the bundled approach includes hand hygiene. It includes the insertion bundle, maximum sterile barrier, skin decontamination before inserting of the catheter, the dressing management, all of these items, including scrubbing the hub and flushing and keeping our tubing from being contaminated by changing it at the right frequencies. It's just such a multifaceted problem with many interventions that have to be done together to prevent CLABSI, which is why when we get a CLABSI, we have to do a root cause analysis and really look at all these components to see was anything compromised. We also make sure that we consider whether the line is even needed. So one component of our CLABSI bundle is, can the line be removed? Is it no longer needed? Because if we can get it out, obviously we can prevent CLABSI. So preventing occlusions, preventing site infections, making sure that we're scrubbing the hub. It's just a big, big approach to CLABSI prevention. And I always say there's not a single bullet to prevent CLABSIs. And a lot of institutions throw a lot of tricks and gadgets at CLABSI prevention. In my organization, we've really tried to focus on the basics of catheter care. No blood or drainage is acceptable under the dressing at any time. Scrubbing the hub, flushing, and maintaining our tubings. And we also have recently, like many other organizations, instituted a mandatory chlorhexidine treatment to the body that has to occur daily for all hospitalized patients that have indwelling central line catheters. We know that this also can help prevent infection and is another great strategy that can be used in an organization to prevent infections. People that are coming in for a catheter insertion from their home should be told to take a shower with an antibacterial soap the night before and the morning of their catheter insertion. That's just another great thing a patient can do to help decrease the amount of bacteria on their skin before coming in for a major procedure like that. And so we do teach that as well. And if they're in the hospital, we do a CHD treatment the night before and the morning of that patient going to get their central line. So CLABSI is just a huge topic, and these are infections that are the most common infection in organizations and the most costly. And we know that we aren't reimbursed if CLABSIs happen in the hospital, and they are reportable conditions. So there's obviously a lot of focus on CLABSIs, most importantly, because we just don't want our patients to have to suffer through something like that and potentially die from a catheter-related infection.
Thank you. MiKaela, you have given us so much information, and I know that our listeners are just going to really, really appreciate this podcast because it's something that every oncology nurse deals with our patients that we care for. And it's just such important information, even if it's a review or if it is something for a new oncology nurse, who's listening. It's valuable, really valuable information. So thank you so much for all of that. And I like to end all of our podcast with 3 quick questions. So we kind of do it kind of rapid fire. I'm going to ask you those questions and finish up our podcast today. So first of all, what are some common misconceptions about central lines?
Well, I think I alluded to a few of them and discussed some of them more in depth. But one is the lack of knowledge about what constitutes a central line and where that tip should be in order to call it a central line. And so tip location, number 1, the notion that a blood return can be absent in a central line, and that's normal. That's not normal. A central line should have a blood return. If it does not have a blood return, it needs to be investigated immediately. We should not give chemotherapy and other caustic drugs through a line that doesn't have a blood return. And there's a misconception that if the doctor writes an order that says it's okay to use because it looks okay on the x-ray, that's fine. But we know that fibrin sheaths can develop, major vessel thrombus can develop. We can have regurgitation or backflow of that fluid and cause extravasations. And ultimately, just think of it like your kitchen sink. You would never let your kitchen sink be backed up and have food going everywhere. You want to keep it clean all the time so that you have the best outcome for your equipment in your house. But also, a patient should not be dealing with a line that has no blood return. Think how much anxiety that causes for our patients to have to go through that every time. So I will refer people back to IR in a blink and say, you know what, this is a newly placed catheter. This line should be functioning. And there is some either mechanical or otherwise problem that is causing this line not to work, and it needs to be fixed. So we've got to stand up for our patients and make sure that we have lines that have blood return and that they are working. And then all lines are not created equal. I think I definitely discussed that in detail.
Thank you. Next question. What is something about central lines that's not often discussed, but you wish more people knew about?
Well, it's a little redundant, but I wrote down tip location with lots of explanation points. Remove them when no longer needed, that they are better than peripheral access. So there's a misconception that some people think central lines are always better. And as I hopefully described, it's not always one size fits all. Risks and benefits have to be thought of before you decide just to put a central line in everyone. And they're not needed in arrest situations. This is a big one. When we're having a cardiac or respiratory arrest, we need to stay on the chest. We know that chest compressions are the most important thing during an arrest. And we have things like bone access, intraosseous access that can be placed in seconds during an arrest, just like they do in the field. And then we can put that central line in a more reasonably quiet and non-chaotic environment so that we don't give that patient an insertion-related infection.
Great. And last question. What are some additional resources for both patients and providers who want to learn more about these devices?
I would say make sure you are reading and looking at your Oncology Nursing Society access device standards. There are other organizations that have standards and guidelines out there for vascular access. I would love to see more standardization with patient ed resources. At my institution, we've written and maintained patient ed handouts and have them loaded into our online platforms for staff to give to patients. And we've also developed videos that patients can access on demand for insertion care and maintenance. But I think we have a long way to go to educate patients about all their options and to help them understand the types of lines and how to make the best choices with their healthcare team.
Well, like I said earlier, MiKaela, thank you so much for all of your insight, and you can tell your passion that you have for the importance of understanding and educating about central lines, their care and their maintenance, and just working with our patient population with these. So thank you so much. Do you have any final comments for us?
I don't think so. I just want to thank you for having me, and thank you for letting me educate nurses about these really important topics.
Well, we appreciate you being on with us today. Thank you so much.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.